Hello, my name is Dr. Adnan Yousaf, and as I told you previously that my mother language is not English, and you may have to wait for some time that I can make you understood some things. And as you know, the knowledge is not a collection that belongs to anyone, and if you have any query or find a mistake in my video, you can discuss it in comment section. So our next page starts from the limbic system. Limbic system is a collection of neural structures involved in emotion, long term memory, olfaction, behavior modulation. Autonomic nervous system function consists of hippocampus. These are the red arrows showing hippocampus in picture A as shown. Amygdala, mammillary bodies, anterior thalamic nuclei, cingulate gyrus. Cingulate gyrus are these the yellow arrows. Entorhinal cortex. This system responsible for feeding, fleeing, fighting, feeling, and sex. So this limbic system, as we have got from this paragraph, it belongs to our emotions. Feeding, fleeing, fighting, feeling, and sex. What are their components? Hippocampus, the one component hippocampus, two amygdala, three mammillary bodies, four anterior thalamic nuclei, five cingulate gyrus, six entorhinal cortex. So the famous 5S. 5S, what are 5X? These are the feeding, fleeing, fighting, feeling, and sex. So these are the dopaminergic pathways. As we previously discussed that dopamine is our motivation hormone or neurotransmitter. So commonly altered by drugs. Yes, dopamine commonly altered by drugs, antipsychotics, and movement disorders, as it's seen in Parkinson disease. The mesocortical and mesolimbic pathways are involved in addiction behavior. As this is a motivation hormone, so it elevates our feelings. So it is a major neurotransmitter or component of addiction. So what are the pathways that involve dopamine? Mesocortical, mesolimbic, nigrostrial, and tuberoinfundibular. I am really enjoying this lecture and this study with you all guys. So, what are the pathways which involve dopaminergic neurotransmitters? Number one is the mesocortical. It projects from the ventral tegmental area to the prefrontal cortex. Ventral tegmental area, which is belong to this mesostructure, may be related to the ventral tegmental area, and the cortical means the prefrontal cortex. So symptoms if altered activity. So what would happen if this is not functioning properly? There would be decreased activity and there would be negative symptoms, as the dopamine is a motivation neurotransmitter and it elevates our mood, so its absence will show negative symptoms. So what is to be noted, that antipsychotic have limited effect. Antipsychotics which we will give in this treatment will have limited effect. So mesolimbic. The next pathway which involves the dopamine is the mesolimbic. Meso again as here it means is showing the ventral tegmental area. The same here, the ventral tegmental area and the limbic system is the nucleus accumbens. Nucleus accumbens is the part of limbic system. So the nucleus accumbens. What would happen if there is decreased function of this mesolimbic pathway? There would be increased activity and positive symptoms. Okay, it is the primary therapeutic target of antipsychotics. So, antipsychotics which we will give in this treatment, they would primarily affect this portion, this pathway. Nigros trial. Nigros trial, I haven't read this, but as we know from previous knowledge that substantia nigra is involved in some kind of activity in the Parkinson's disease. So what happens we see again. Nigro means nigra substantia nigra to the striatal, dorsal striatum. So this is the pathway and its function is to control motor system of our body. So we pronounce it as nigro striatal. Striatal. Yes, stride. Stride mean to move, to walk, I think so. Stride, our walk is also called stride. So in Parkinson's disease, there is a typical walk. So maybe that's why they have this mnemonic. What would happen if there is a defect in this pathway? There would be decreased activity, and there would be extra pyramidal symptoms. So what is to be noted here, significantly affected by antipsychotics and in Parkinson's disease. Tubero-infundibular. Tubero, again hypothalamus, from hypothalamus to the infundibulum shows the pituitary. From hypothalamus to the pituitary, this pathway is from hypothalamus to the pituitary. What does it do? It regulates the prolactin secretion. Regulation of prolactin secretion. Its defect would decrease the activity and increase the prolactin and significantly affected by antipsychotics. So in this table we have discussed four pathways which are involved in the which involves dopamine. Two pathways are from ventral tegmental area, the mesocortical and mesolimbic, and the other pathway is the nigrostriatal, which is from the substantia nigra, and the tuberoinfundibular, which from the hypothalamus. So all these have different effector areas, just like the first one have prefrontal cortex, the second have nucleus accumbens, and the other have dorsal striatum, and the last one have pituitary. All these have different functions, and all these have different symptoms if they are affected, and all these are involved with different kind of disease and have different response to the antipsychotics. So which one of the pathways have a good response? And the primary target, the mesolimbic, has the very good therapeutic target of antipsychotics. This nigrostriatal is also significantly affected by antipsychotics, and tuberoinfundibular is also significantly affected by antipsychotics. So what is this picture showing? This is showing, this is the hypothalamus, and this is the nucleus accumbens, and this is the pituitary gland, ventral tegmental area. If we have mesocortical, ventral, what is ventral tegmental? This is the ventral tegmental area, and we have two effector areas, from ventral tegmental areas to the prefrontal cortex, which is the mesocortical, and from ventral tegmental area to the nucleus accumbens. Where is the nucleus accumbens? This is the nucleus accumbens. This red one is showing the nucleus accumbens. So the other one is the substantia nigra and the dorsal striatum. Where is the substantia nigra? Yes, this is the substantia nigra, and from this the signals are going toward the dorsal striatum. Tuberoinfundibular. This pathway is from hypothalamus. Yes, hypothalamus towards the infundibulum, which is located in the pituitary gland. So you can easily remember from this diagram too. The next page is showing the cerebellum. It modulates the movement. We already know when it is defected, we have different abnormalities of movement. So it modulates our movement, aids in coordination and balance. Yes, this main word, the balance. It is involved in balance. Ipsilateral unconscious proprioceptive information via inferior cerebellar peduncle from spinal cord. Ipsilateral proprioceptive information from the cerebellum will go towards the spinal cord. Okay? No, sorry. The spinal cord will have the signal of proprioceptic information, and these will go towards the ipsilateral cerebellar peduncle. Yes, this is the correct form. Deep nuclei, dentate, aboliform, globus, vestigial, don't eat greasy food. It contains deep nuclei. What are these deep nuclei? From lateral to medial? As from go from lateral to medial, and from here lateral to medial, the most lateral is dentate, then the aboliform, then the globus pallidus, and the fastigial. Don't eat greasy food. Don't dentate. Eat aboliform. G for globus pallidus and F for fastigial. So there are the hemispheres. Medial cerebellar hemisphere, which is also called vermis, and it controls axial and proximal limb musculature bilaterally medial structures. And the lateral cerebellum hemispheres, these control distal limb musculature ipsilaterally, and the lateral structures. Test. What are the tests from with which we can diagnose the cerebellar pathology? Rapid alternating movement, pronation, supination, as I can show, we do this, and just like this, pronation, supination, finger to nose, finger to nose, finger to nose, heel to shin gate, from heel to shin gate, heel to shin gate. Look for intention tremor as we go to grasp something, and we will have the intention tremors, just like this. So what this picture is showing, this is the cerebellar input. Obviously the cerebellar input comes from the spinal cord, and as we discussed here, and the other will come from the contralateral cortex, and this will be relayed in the deep nuclei, and it will show the output in the form of cerebellar cerebellar peduncle and toward the contralateral cortex. Mm, so inner ear vestibular nuclei and floculonodular, maybe this is discussed ahead. There is no any discussion about the flocculonodular lobe. The lateral cerebellum we have discussed is a medial cerebellum we have discussed it too. So the flocculonodular lobe is some kind of associated with the inner ear structure, the vestibular nuclei, which is also involved in the balance. Yes. The next page is discussing about the basal ganglia. Yes, basal ganglia, very important structure. It is important in voluntary movement and adjusting posture. It is also associated with adjusting our posture. Receive cortical inputs, provide negative feedback to cortex to modulate movement. Negative feedback. It is some kind of uh, a negative feedback which shows that these movements are not required, and other which show the positive. When it show the positive means these movement will occur, or if the basal ganglia is damaged, so there is no negative feedback, there is no inhibition though, so we will have exaggerated movement. Yes, this from these two lines I have grasped some kind of concept which look like this to me. So let us read it ahead. And negative feedback to cortex to modulate movement. Striatum is the putamen motor plus caudate nucleus cognitive. Lentiform nucleus is putamen plus globus pallidus. So the direct excitatory pathway. It is excitatory pathway. Cortical input via glutamate stimulate GABA release from the striatum, which inhibit GABA release from the GPI. Activating the thalamus, increasing the motion. As it is showing as the excitatory, so it is involved in some kind of movement, positive movement, so it increases our motion. How it increases our motion? It receives cortical input by the glutamate. Glutamate is a stimulatory neurotransmitter, and it stimulates the GABA release from the striatum, which inhibit GABA release from the GPI. Hmm. Indirect inhibitory pathway. It also receives cortical input via the glutamate. It stimulates the GABA release from the striatum, which inhibit GABA release from the GPE. This inhibiting activating the STN. STN input via the glutamate stimulate GABA release from GPI, inhibiting the thalamus, so decrease the motion. So previously in direct pathway, when the GABA is released, it inhibit GABA release from the globus pallidus, which is the inhibitory part of the globus pallidus. So activates the thalamus. And in this pathway, uh, this GABA release inhibit the GABA release from the globus pallidus excitatory portion, which is also a part of globus pallidus. So it activate the STN, and STN input via the glutamate stimulate GABA release from the GPI. So it inhibit the thalamus, decrease motion. Dopamine from substantia nigra stimulate the direct pathway and inhibit the indirect pathway. As the dopamine is the excitatory neurotransmitter, So it stimulates the direct pathway, which increases the motion, and inhibit the indirect pathway, which decreases the motion. So what is in this diagram? This green one is showing the stimulatory, and this red one is showing the inhibitory. So uh, from substantia nigra, this sorry, here from substantia nigra, the green signal, which is the stimulatory, it goes towards the direct pathway, and the red one, which is the inhibitory, goes towards the indirect pathway. And these globus pallidus, which is inhibitory, it will send signal to the thalamus, negative signals, and prevent the movement. And this globus pallidus, which is the excitatory, it is sending signal to the substantia nigra, which is sending back to the globus pallidus inhibitory portion. So very complex diagram, nothing to remember, just go to the text, and you can remember all these things. So the next page comes with the cerebral cortex regions. As we know, there is the cerebral prefrontal cortex, yes, the frontal lobe, and the frontal eye field, the prefrontal cortex, and the Broca's area, Sylvian fissure, limbic association area, temporal lobe, and all these things. You can have a look on it. The somatosensory association area, vernix area, primary visual cortex, and the primary auditory cortex, which is located in the temporal. Wernicke area and primary auditory cortex, and the limbic association area is located in the temporal lobe. Yes, what is the cerebral perfusion? It relies on tight autoregulation, primarily driven by the partial pressure of carbon dioxide. Partial pressure of oxygen also modulate perfusion in severe hypoxia. So it is majorly driven by the partial pressure of carbon dioxide, which means when there will be increased carbon dioxide, there would be increased perfusion. So also relies on a pressure gradient between the mean arterial pressure and the intracranial pressure. Decrease blood pressure or increase intracranial pressure, decrease cerebral perfusion pressure. Yes, this thing is to remember that when there would be decreased blood pressure and increased intracranial pressure, this will decrease the cerebral perfusion pressure. What is Cushing reflex? Cushing reflex, it is a triad of hypertension, bradycardia, and respiratory depression in response to increased intracranial pressure, which most of the time happen in the cranial injuries where there will be increased intracranial pressure due to the leakage of blood. This will result in the into the hypertension. Mainly the systolic blood pressure would be increased. There would be bradycardia and respiratory depression. So what is this? Therapeutic hyperventilation means when there would be decreased carbon dioxide, there would be vasoconstriction, decreased blood flow, decreased intracranial pressure may be used to treat acute cerebral edema secondary to stroke, unresponsive to other interventions. So here is the uh, cerebral perfusion pressure, which is equal to the mean arterial pressure minus the intracranial pressure. So here you can see if there is increased intracranial pressure, the cerebral perfusion pressure would be decreased. And if CCP is zero, there is no cerebral perfusion. Brain death will occur, absent brainstem reflexes and apnea, and at last death. So the next one is hypoxemia, which increases the cerebral perfusion pressure only if partial pressure of oxygen is less than 50 mmHg. Cerebral perfusion pressure is directly proportional to the partial pressure of carbon dioxide until partial pressure of carbon dioxide is greater than 90 mmHg. So here you can see the curves. The y-axis is showing cerebral blood flow. Yes, this is the ml per 100 gram per minute, and this is the pressure which is in mmHg. So when there is increase partial pressure of carbon dioxide, there would be increased mean arterial pressure, and mean arterial pressure is directly proportional to CCP. So increased partial pressure of carbon dioxide is directly proportional to CCP, as we have discussed in this line. And there is a decreased partial pressure of no, so this partial pressure of oxygen would decrease as the partial pressure of carbon dioxide is decreasing also, so they are interrelated to each other. The next page is about the homunculus. Yes, homunculus is like a human structure, and we can see here this there's a hand and mouth and legs and feet and this head and the face. All this is the homunculus. This is the motor homunculus. This is the sensory homunculus. So topographic representation of motor and the sensory area in the cerebral cortex. What is homunculus? It is a topographic representation of motor and the sensory area in the cerebral cortex. So this is distorted. Hand is somewhere else, leg is somewhere else, face is somewhere else, and the head is somewhere else. So this distorted appearance is due to certain body regions being more richly innervated and thus having increased cortical representation. Yes, you should have to remember it. And you can see that these medial side of the cerebral hemisphere are showing the nerve supply of the leg, the toe, the ankle, the knee, the hip, the trunk, and same here is the case. So cerebral arteries. So which cerebral artery is supplying to which portion of the brain? The anterior cerebral artery is supplying the yellowish portion, anterior cerebral artery. This is the lateral side, and this is the medial side, and this is the basal side. So you can say that the anterior portion of the frontal lobe, anterior, and the medial portion of the frontal lobe is mainly supplied by the anterior and the medial surface. Yes, anterior cerebellar artery, and the middle cerebral artery, which is this is the green shadow. This supplies the lateral surface of the frontal cortex and the temporal lobe, upper half of the temporal lobe. And the posterior cerebral artery is supplying the posterior and the inferior surface. Yes, this is the posterior surface from lateral to the medial and the basal surface. This is the inferior surface. What is watershed zone? Oh, sorry. Yes, what is watershed zone? Cortical border zones occur between anterior and the middle cerebral artery and the posterior and the middle cerebral arteries. Blue area. Yes, these are the structures which are going to occur between the territory of two arteries. Yes, this portion is between the anterior and the middle cerebral artery, and this portion is between the posterior and the middle cerebral artery. So, internal border zones occur between the superficial and the deep vasculature territory of the middle cerebral artery, red area. Yes, this red area is between the deep vascular territory of the middle cerebral artery. Yes, this middle cerebral artery. Common location for brain metastasis, infarct due to, yes, it is a common location for brain metastasis, infarct due to severe hypoperfusion, and anterior communicating artery and the middle cerebral artery watershed infarct, proximal upper and the lower extremity weakness, man in a barrel syndrome. Man feels like he is in some kind of barrel, and it occurs in the anterior communicating artery and the middle cerebral artery watershed infarct. Posterior communicating artery and middle cerebral artery watershed infarct, which would occur here, it looks like higher order visual dysfunction as it is involving the occipital lobe, so it will involve the higher order visual dysfunctions. So, let us go to the next page. And very important structure, all things are important which are discussing here in this video. So this is the circle of Willis, system of anastomosis between anterior and the posterior blood supplies of the brain. So anterior communicating artery, as it is communicating two arteries, so it is the anterior communicating artery. Anterior cerebellar artery, as it is supplying the anterior portion of the cerebellum, and this here middle cerebral artery, and which is supplying the lateral side and some of the inferior side of the cerebellar hemisphere, this middle cerebral artery, and which the artery which communicate the middle cerebral artery and the posterior cerebral artery is the posterior communicating artery. Yes, here. So this is the circle which is showing here. This is the circle of Willis. So the posterior artery, which shows the basal side of the occipital or the occipital lobe, and there are a lot of branches here, superior cerebellar branches and the anterior inferior cerebellar branches and the posterior inferior cerebellar branches. This very great structure here is the basilar, and these two structures are the ventral, and which are arising from these and uniting here, these showing the anterior spinal artery. So you should you have uh, there is nothing to remember here, all these structures except the circle of Willis, and by which arteries this circle is formed. We can see again the anterior communicating, the anterior cerebellar, the middle cerebellar, posterior communicating, some part of the posterior cerebral artery, cerebellar, not cerebellar, oh my god, anterior communicating, anterior cerebral, middle cerebral, posterior communicating, posterior cerebral, and again these structures. So yes, you can see here again these structures, and dural venous sinuses. Dural venous sinuses, yes, large venous channels that run through the periosteal and meningeal layer of the dura mater. drain blood from the cerebral veins. Arrow. Where is the arrow? Yes, these are the cerebral veins, and these drain this blood and receive CSF from the arachnoid granulation, empty into the internal jugular vein. So venous sinus thrombosis. Venous sinus thrombosis which occur in these sinuses is the venous sinus thrombosis, presents with the sign and symptom of increased intracranial pressure, as this thrombus would cause blockage of the blood flow, so it will increase automatically the intracranial pressure, which result in the headache, seizures, papilledema, focal neurological deficit, may lead to venous hemorrhage, and it is associated with the hypercoagulable state, as it is occur in pregnancy and oral contraceptive pill use and factor 5 leiden. These are the structure, the superior sagittal vein sinus and the inferior sagittal sinus, which is going parallel to this structure, the great cerebral vein of Galen. Yes, great cerebral vein of Galen. This is the straight sinus, and the confluence of sinuses with a lot of sinuses which drain here, and this structure is the confluence of sinuses, and the sinus here is in occipital lobe, is showing the occipital sinus, and the which is going transversely is called the transverse sinus, and transverse sinus then form an S-shaped structure which will form a sigmoid sinus and the jugular foramen, and which these will drain into the internal jugular vein. Yes. So the next is ventricular system. Yes, ventricles which contain the CSF. So there are four ventricles of brain, as we already know, two lateral ventricles and third and fourth ventricle. Lateral ventricle. Third ventricle. Lateral ventricles drain into the third ventricle via the right and the left interventricular foramina of Monro. Then third ventricle will go into the fourth ventricle via the cerebral aqueduct of Sylvius. Yes, fourth ventricle will go to the subarachnoid space via the foramen of Lusca lateral and foramen Magendie medial on the medial side. So this belongs to anatomy. Yes, you can remember it, but not important. So CSF made by choroid plexus located in the lateral, third and fourth ventricles. So all these four ventricles are creating the or making or producing the CSF. This travel to the subarachnoid space via foramina of Lusca and Magendie, Lusca lateral and Magendie medial, and is absorbed by the arachnoid granulation and then drain into the dural venous sinuses, as we have discussed it previously. So the next structure is the brain stem, ventral view. Yes, this is the brain stem showing the ventral view. Brain stem, a lot of structures, very complicated. Ventral view. Yes, this is the optic chiasm where two optic nerves meet, and this is the infundibulum of the pituitary gland. These are the mammillary bodies. Yes, here and here. This is the pons and the middle cerebral peduncle. Yes, this is the pyramid and the pyramidal decussation and the cranial nerve 1. And yes, this is showing the olfactory bulb, cranial nerve, olfactory tract, and the optic tract, and the yes, this is the optic tract, and this is the cranial nerve 3. This is cranial nerve 5, and yes, this is 6. This is 5. This is 7. This is 8. Sorry, this cranial nerve is 6. This is 7. This is 8. 9, 10, 11, 12. Very complicated. 4 cranial nerves are above pons. 1, 2, 3, and 4. Let us see. Olfactory nerve, optic nerve, yes, this third nerve and this fourth nerve. These are above the pons. 4 cranial nerve exit the pons. 5, 6, 7, and 8. Yes, 5, 6, 7, and 8. This is the 5 exiting the pons, 6 exiting the pons, 7 exiting the pons, and this is the 8 which is exiting the pons. This is the structure pons showing here. 4 cranial nerves are in medulla. 9, 10, 11, 12. Medulla. Yes, this is medulla. And this is 9, 10, 11, 12. 4 cranial nerve nuclei are medial. On the medial side. Yes, on this side. What are these? 3, 4, 6, and 12. 3, 4, 6, and 12. Yeah, the next portion is also the brainstem, but this is the dorsal view, and the cerebellum is removed. Cerebellum, which was the structure below here, is removed. So what is this? Let us see. These drum-like structures here, these are the thalamus, and this is the third ventricle. Yeah, this round structure is the pineal gland, and the superior colliculus, inferior colliculus, and this is the superior cerebellar peduncle, inferior cerebellar peduncle, middle cerebellar peduncle, and this is the anterior wall of fourth ventricle, and this downward structure is the medulla, and below this would be spinal cord. So what is the pineal gland? It secretes melatonin, which is involved in circadian rhythms. We have discussed it previously. Yes, the second structure is the superior colliculus. This superior colliculus direct eye movements to stimuli or objects of interest. Superior colliculus is involved in direct eye movements to stimuli, noise, or movement or objects of interest. Inferior colliculus is involved in the auditory pathways. So your eyes are above, your ears are above your ears. So superior colliculus is involved in eyes, and inferior colliculus is involved in auditory ear structures. And the superior colliculus visual is above, and the inferior colliculus auditory, which is below. So wow. The second, the next page is showing the cranial nerve nuclei. So located in tegmentum portion of the brainstem, tegmentum portion of the brainstem, between dorsal and the ventral portions. Lateral nuclei are sensory, and the medial nuclei are motor. Alar plate and lateral nuclei are found by the alar plate, and the medial nuclei are found by the basal plate or ventral plate. Yes. So midbrain, midbrain contain nuclei of cranial nerve 3 and 4. Pons contain nuclei of 5, 6, 7, 8. Medulla contain nuclei of cranial nerve 9, 10, 12, and spinal cord contain nuclei of cranial nerve 11. Yes, accessory nerve. So you may remember this. Yes, looks like important. So again, Midbrain have nuclei of 3 and 4. Pone have nuclei of 5, 6, 7, 8. Medulla have nuclei of 9, 10, 12. And spinal cord is especially of, sorry, spinal cord contain nuclei of cranial nerve 11, accessory cranial nerve. Vagal nuclei. Vagal nuclei means this 10th cranial nerve. Vagal nuclei, these nuclei are in medulla. Nucleus tectus solitarius. Function. What is its function? It is visceral sensory information like taste, baroreceptor and gut distension. May play role in vomiting. Nucleus tectus solitarius. Cranial nerves which are involved, these are the 7, which is all involved in taste, coda, tympani, you may know. Cranial nerve 9, which is the glossopharyngeal nerve, and the 10, which is involved in the, and glossopharyngeal nerve is involved in the baroreceptor response, and the vagus nerve too, and the gut distension is related to the cranial nerve 10. So may play role in vomiting. Okay, vomiting, yes. The vagus nerve is in gut distension, so this may involve in vomiting. Nucleus ambiguous. Solitarious sensory information and ambiguous is carrying the motor innervation of pharynx, larynx, upper esophagus, swallowing and palate elevation. Cranial nerves involved are 9 and 10. You may remember it from the gag reflex, which is related to cranial nerve 10, and the pharynx is involved in gag reflex. Larynx, yes, most of the laryngeal muscles are supplied by the vagus nerve, you know, and very important structure, recurrent laryngeal nerve or external laryngeal nerve. These are all branches of the vagus nerve, and upper esophagus. These are also associated with the vagus nerve. Dorsal motor nucleus. It sends autonomic parasympathetic fibers to the heart, lung, and upper GI. This wholly are of 10 cranial nerve. Yes, vagal stimulation decreases the heartbeat and causes bradycardia, and vagal stimulation also constrict the bronchioles when we are relaxing, and it may increase the upper GI movement as we are relaxing in the parasympathetic response. So the next page, which comes with this bloody look diagram, is the midbrain. Yes, this is the superior. Yes, tell me, superior calculus. In which pathway it is involved? Yes, yes, tell me. Yeah, well, yes, exactly. It is involved in the eyes, visual pathway. Cerebral aqueduct, it is connecting the third and fourth ventricle, and the cranial nerve 3 nuclei, and cranial nerve 3 fibers. These are the fibers, and the medial lemniscus, and the red nucleus, and the substantia nigra, and the crus cerebri. Yes. So pons. This is the fourth ventricle. This umbrella-like look, fourth ventricle, and these here are the medial longitudinal fasciculus, middle cerebellar peduncle, and cranial nerve 5 nuclei, corticospinal and corticobulbar tracts, and the medial lemniscus, superior cerebellar peduncles, yes, and the medial lemniscus. So today's last diagram, yes, you may be happy. This is the last diagram which we will discuss. It is of medulla and inferior cerebellar peduncle two cerebellar peduncles were in the pons. This middle cerebellar peduncle and the superior cerebellar peduncle. And the inferior cerebellar peduncle is in the medulla. Medial longitudinal fasciculus. Yes, medial. Yeah, the medial. Here also the medial longitudinal fasciculus in the pons and medial longitudinal fasciculi in the medulla too. Nucleus ambiguous. It wasn't present in the pons. It is present here. Inferior olivary nucleus. It wasn't present in the pons and it is present here. It also contains the pyramids and it is contains the medial lemniscus. The above structure was also containing the medial lemniscus, but this small portion. And these three structures are related to the cranial nerve 10. These nuclei showing the cranial nerve 12 nucleus and the dorsal motor nucleus and the nucleus tectus solitarius. Nucleus tectus solitarius, which is the vagal nucleus, and it was involved in the sensory pathway as we have discussed it here. Visceral sensory information like taste, baroreceptor, and the gut distension. And it have cranial nerves 7, 9, and 10. Yes, and yes, this is complete. Today we have completed it, and if you have any kind of query we can discuss in the comment section, and if you haven't remembered it you can again watch this video, and we will see each other in the next section. Okay, goodbye.